This is Selma Schimmel for the group room at the annual San Antonio Breast Cancer Symposium, where we're now joined by Dr. Hope Rugo, Professor of Medicine and Director of Breast Oncology Clinical Trials and Education Program at the University of California, San Francisco Comprehensive Cancer Center. Hello, Dr. Rugo.
Hi.
Let's talk about the importance of young women and their response to neoadjuvant chemotherapy and what that means exactly.
Well, young women, of course, it represents a big challenge. Young women have very dense breasts, and so there's been a sense for a long time that young women might be diagnosed later than older women because of the dense breasts, maybe because of misdiagnosis, because it's not very common to the general practitioner that they might sort of say, oh, come back in 6 months, something like that. But it's interesting, actually. I think we've understood more recently that the biology is different based on age, so that young women tend to have more aggressive biology in their tumors, meaning that, you couldn't have diagnosed them earlier. They are the kind of cancers that pop up in between visits in older women. And this study done in Germany with many other investigators looked at a huge number of women and really focused on the differences between very young women, so up to the age of 35, then the sort of middle range, which was 36 to 50, and then women over to the age of 50, and tried to look at differences in the type of cancers that women had and their response and then their outcome based on these 3 different age groups. These women were all enrolled in neoadjuvant chemotherapy trials, and the patients who had hormone receptor-positive disease also received hormone therapy afterwards. What they found is actually very interesting, and I think that it goes along with our general bias, which has been for a long time, is that younger women tend to get more aggressive biology tumors, essentially. And that is that the so-called triple-negative breast cancers that are hormone receptor negative and HER2 negative, although their definition was a little different than some others, so it wasn't completely negative on the estrogen receptor, but close to it. Triple-negative breast cancer was more common in the young women than it was in the older women. So about 1/3 of the younger women had breast cancers. It was only 1/4 of the middle age group and about 1/5 of the women who were over the age of 50. So really a big difference. And then when you looked at sort of some of the other variants that we see, hormone receptor positive breast cancer, even HER2 new positive breast cancer, the differences weren't as striking. Patients who were younger tended to have more invasive cancers that were high grade, and that goes along with it. More node negative and less very big tumors, I think because they come in right away when they get these aggressive cancers. So then they looked at what is the response of these cancers based on age. And it was interesting because the younger women seemed to have a better pathologic complete response rate. And they defined this very strictly: no invasive cancer in breast or lymph node. No cancer at all. And the rates were higher in younger women than older. Then when you separated it out, it really turned out that these were women who had the triple-negative breast cancers that respond very quickly to chemotherapy if they're going to, have a higher pathologic complete response rate than hormone receptor-positive slow-growing cancers. So they had a higher rate. The last thing they looked at was whether or not your ability to have a pathologic complete response affected your outcome. And of course it did, very strongly so that younger women who didn't have most of their disease go away when they had these bad biology cancers had more recurrences. So this kind of information, looking at a large database from many trials, helps us a lot because it means that for younger women, even more than the older women, when they have these cancers that aren't responding right away to treatment, that we really have to be thinking about clinical trials, new directions. These are the kinds of patients we should be enrolling in clinical trials up front to try and find the best treatments.
When we talk about neoadjuvant chemotherapy, which means they're going to have chemotherapy before surgery with the goal of shrinking tumor, that's applied to women depending on their tumor size of various ages, though, is it not?
Yes, it is, and we don't use age mostly as a determinant of where to use neoadjuvant therapy. Neoadjuvant therapy has traditionally been used as a way to convert a patient who needed to have a mastectomy to potentially the possibility of breast-conserving surgery or lumpectomy, and independent of age. Now, the caveat with that are several things. One is, as you get much older, you don't tolerate chemotherapy very well, so you might not be wanting to take that approach if you're, 82 and have multiple other medical problems. The second is that older women tend to have the slower growing hormone receptor positive cancers that might not benefit from the neoadjuvant chemotherapy. And the last is that our thinking has changed a lot, although I have to say it's thinking that's changing in pockets more than as a universal change. And that's that if you're going to give chemotherapy anyway, why not give it first? Because the way we give chemotherapy is in the dark. You know, you got the surgery, you have no cancer that you can see, you know you have a risk of recurrence, so you get chemotherapy. At the end of the treatment, the patient says to me, so did it work? And we say, well, come back in 5 years or 3 years or 20 years. And so if you do neoadjuvant therapy by the response, particularly in these faster growing cancers, we can better understand what the risk is, what your chance of being cured of the cancer is, whether we should be looking at additional treatments. And it's an excellent way to test new agents. So agents that look promising, we can add them to our standard treatment, as in the national, now international I-SPY 2 trial, and get an idea of which cancers respond.
And in this young adult patient population, it really has nothing to do with the size of the tumor. In this case, you're talking about the fact that they're potentially more aggressive, fast-growing, and so the size of the tumor has no impact on, that's not what's driving the neoadjuvant approach.
Pretty much not, but I mean, we don't give neoadjuvant chemotherapy for a cancer where we're not sure we're going to give chemotherapy. So, 0.5 centimeter tumor, you're not going to give neoadjuvant chemotherapy, tiny little thing. But it doesn't mean that your tumor has to be so big that you need a mastectomy. In fact, shrinking the cancer can give us information that's incredibly important to you and potentially offer you new therapies that are changing the way we treat breast cancer.
Thank you. Dr. Hope Rugo, Professor of Medicine and Director of Breast Oncology, Clinical Trials and Education at the University of California, San Francisco Comprehensive Cancer Center.
Thank you very much.
Thank you.